Sukant. Welcome back to my channel. In this video, I will discuss about acute appendicitis. Before we discuss acute appendicitis, first we will talk about surgical anatomy of appendix. In surgical anatomy, first we need to know various location of appendix. You can see here. The most common location of appendix is retrocecal. Second most common location is pelvic, and the least common location is postileal. You also have to know that it is most difficult appendicitis to diagnose. Appendicular artery. Appendicular artery is the branch of lower division of ileocholic artery. Also called end artery, it is very important. Note: one very important thing about appendicular artery. If this is the appendix, and this is mesoappendix, the mesoappendix is the mesentery. The appendicular artery lies in the mesoappendix. But the terminal part of the mesoappendix artery is not covered by mesentery. So the terminal part which is not covered by mesentery, it can get thrombus easily during inflammation. Therefore, perforation is most common at the apex of appendix. In some patient, there can be accessory appendicular artery as well. This accessory appendicular artery, also known as the artery of Sesquicolum, is an Indian surgeon. This is the branch of the postcaecal artery. Appendix base has a constant location at the junction of three tinea coli. Acute appendicitis. It is the inflammation of appendix. Types of appendicitis. You can either have obstructive or can be catarrhal or non-obstructive appendicitis. Obstructive is much more common as compared to catarrhal appendicitis. So obstructive appendicitis, as the name suggests, the lumen gets obstructed. If the lumen get obstructed, then the luminal pressure increases. There is increased pressure in the lumen. Because of increased pressure in lumen, first lymphatic blockade occurs. As the pressure increases more, then venous blockade occurs, and finally, because of increased pressure, there is arterial compromises, or there can be perforation. So these are the various steps in acute appendicitis, or this is how acute appendicitis proceeds. Now the question is, what blocks the appendix? So the most common cause of blocks or obstruction is phacolith. Phacolith have a composition of calcium phosphate. Note: calcium phosphate is also found in the stone of prostate, salivary gland, and phascolith. Other things which can block the lumen are ascariasis, carcinoid tumor, or foreign body that can also block the appendix. Catarrhal appendicitis. Catarrhal appendicitis can be seen in children, and this is non-obstructive. Clinical feature. Acute appendicitis is rare in infants. It is common in children. And in children it affects both male and female equally. The maximum incidence in teenage, male is more than female. But in adults it again male and female affected equally. Now symptoms, signs, and lab findings. We can get all of these in MANTRELS scoring system or modified Alvarado score. The mnemonic is MANTRELS itself. So look at the first alphabet of each point, which is mentioned here. M is for migration of pain to right lower quadrants. A is for anorexia. N is for nausea and vomiting. T is for tenderness in right lower quadrant. R is for rebound pain. E is for elevated temperature. L is for leukocytosis. And S is for shift of white blood cell count to left. So these are the MANTRELS scoring system, and in this system all the criteria are given a score of 1 except for 2 criteria. The 2 criteria which is given for 2 is tenderness in right lower quadrant and leukocytosis, making the total score of 10. In MANTRELS scoring system, first 3 characteristic is symptoms, next 3 criteria is signs, and last 2 characteristic are lab findings. According to this system, if the score greater than equal to 7, then it more likely to be appendicitis. And if it has less than 7, then appendicitis is unlikely. There are 2 more scoring system you should know, are Zanacchi score and Ripesa score. So in symptoms, anorexia is most common and fever is late or uncommon. If we talk about signs of acute appendicitis, then we should know that there is tenderness at McBurney's point. A lot of times it has been asked that where is this McBurney's point situated? So the McBurney's point is situated at the lateral 1/3 and medial 2/3 junction. So here is umbilicus and this is anterior superior iliac spine. So this the line joining these 2 points, and the McBurney's point is situated at the lateral 1/3 and medial 2/3 junction. Here is the tenderness. You can have Ravsing sign. What is Ravsing sign? When we press left iliac fossa, then pain in right iliac fossa. This occurs because movement of air from the left side to right side, and that irritates the appendix. Another sign is psoas sign or Cope-Psoas test. Psoas sign can be elucidated by either hyperextension of right hip causes pain or flexion of right hip against resistance causes pain. Another sign is obturator sign. Obturator sign is flexion and internal rotation of right hip can give rise to pain. Now there are certain non-specific signs which give pain. Like Dunphy sign, pain on coughing. Ten horn sign, pain on pulling right testis. Aaron sign, from pressure in right iliac fossa, pain in epigastrium. Differential diagnosis. If we talk about infants and children, we can see Yersinia infection, which give rise to mesenteric adenitis. And in mesenteric adenitis, fever is common. Other thing you can have intussusception, bowels obstruction can be there, ureteric colic and Meckel's diverticulitis. In adults we can see ureteric colic, gastroenteritis, bowel obstruction and torsion. In adult females we can see Mittelschmerz, which is mid-cycle ovulatory pain. We can see endometriosis, pelvic inflammatory diseases and ectopic pregnancy can also be seen. In elderly patients you can see diverticulitis, ureteric colic and obstruction. Investigation of choice to confirm the diagnosis. CECT in adults. And USG in children. And what are the signs which we see on the ultrasound? You will see elongated tubular structure, and this elongated tubular structure is non-compressible, it will be blind ending. When you put pressure with the probe there will be probe tenderness. There will be free fluid around appendix. And the diameter will be more than 6 mm, so these are some signs which we can see on ultrasound. We diagnose the patient. Now how can we manage the patient? If the patient is coming with acute appendicitis, then the best option is to carry out appendicectomy. This appendicectomy can either be open appendicectomy or laparoscopic appendicectomy. The incision for open appendicectomy is McBurney incision. And the McBurney incision is divided into 2 types. You have the gridiron incision and Rutherford-Morrison incision. Gridiron is the muscle-splitting incision and Morrison is the muscle-cutting incision. McBurney incision is the emergency appendicectomy. And we know that emergency incision is the contaminated procedure. Another incision which can be used is Lanz incision or skin crease or bikini incision. This is cosmetically superior incision, and this is used for interval appendicectomy. And interval appendicectomy is the clean contaminated procedure. You can another incision called Rocky Davis incision. And you can have lower midline incision. Lower midline incision is used when there is appendicular perforation. Note: appendicectomy in Crohn's disease. If Crohn's disease is controlled, then go for appendicectomy, but if there is active Crohn's disease, then go for conservative management. Because if we do the surgery now, then that can give rise to fecal fistula. In laparoscopic appendicectomy, we put 3 trocars. One in infraumbilical, next in hypogastric, and one in the left iliac fossa. Complication of appendicectomy. Complication can be hemorrhage. Injury to iliohypogastric nerve. This is the most common nerve which can get injured during appendicectomy. If this is injured, then this can increase the incidence of right inguinal hernia. Next is wound infection. This is the most common. There can be fecal fistula, there can be portal pyemia. Portal pyemia is the one when infection spread into the biliary tree, and this can be life-threatening condition as well. Next is stump appendicitis and adhesive intestinal obstruction. This is most common long-term complication. That's all for this video. If it is informative, click on the like button, and you are new to this channel, then subscribe the channel.